Hello all, this is Marc Levitt coming to you from Washington, D.C. Thrilled to be part of this case-based learning that has been set up by my good friend Sharif. We present a case of a 6-year-old male with an anorectal malformation who underwent, in the first year of life, colostomy, ARM repair with PSARP, colostomy closure, and then had subsequent multiple urinary tract infections leading to renal damage and ultimately a kidney transplant. What were your next steps? Well, one option was to give prophylactic antibiotics to prevent UTIs. Certainly a reasonable choice, but we have to find the source of these UTIs. Perform a vesicostomy for neurogenic bladder. Yes, of course, ARM patients may have neurogenic bladder. We need to know the status of their spine, and we need to make sure that their bladder is successfully empty. But the correct answer is to obtain imaging. We need to look for a complication that may be causing this. So with that image, and we show that in the slides that you're seeing, a pelvic MRI is absolutely vital. You can see here that there is a presacral mass. There is a mass behind the bladder in front of the sacrum, and in this rare case, the mass is actually adherent to the underside of the hollow of the sacrum. Well, this represents a remnant of the original fistula, a so-called roof. We used to call these posterior urethral diverticulum, but they are neither urethral nor are they diverticula, so I decided it would be best to change the name to a roof, which explains exactly what it is. The surgeon was a bit too timid and did not dissect out the distal rectum, leaving the distal rectum adherent and connected to the urinary tract, seeding the urinary tract, causing urinary tract infections. So you need to do an MRI. I also like to do a cystoscopy because one may show the roof, one might not. If you think about it, if the roof is decompressed without urine in it, the MRI won't show it. And sometimes the urothelium heals and the presacral mass exists, yet the urethra has self-repaired. You need to find these things and then remove them through a posterior sagittal incision. Some of you mentioned laparoscopy, which is certainly an option for this difficult location. However, in this case, I chose PSARP because of the very difficult dissection I anticipated of the adherence of the roof to the hollow of the sacrum. Remember, when you have a patient with an ARM after their repair who is not doing well, you need a formulated protocol to figure out what's wrong with them, and looking for such a roof would require both cystoscopy and MRI. You may also have a rectum that needs to be repaired because of prolapse, stricture, or mislocation. But don't go and fix those until you've looked to make sure there's not a roof behind all of that that also needs to be removed. Great to interact with all of you in this format, and I hope to see you again soon. Bye-bye.